Okay, so thank you very much for coming today. And welcome to the introductory lecture on autism. In this lecture, we'll focus particularly on how autism expresses itself in the first 3 years of life. We're going to talk about core features, comorbid characteristics. We'll talk a little bit about broader autism phenotype and spend some time trying to understand what might be the earliest signs of autism that are present in babies way before behavioral symptoms of autism come online. Autism is a complex neurodevelopmental disorder. It affects in a profound way how children interact with other people. Also produces a series of very unusual behaviors having to do with rigidities, repetitive motion, and stereotype interests. It's one of the most prevalent neurodevelopmental disorders, affecting 1 in 68 children in general population. Thus far, we really don't have biological markers or medical tests that can be performed to determine whether the child does or doesn't have autism. For that reason, in order to diagnose the child, we have to perform a close analysis of the child's symptoms and behaviors. It's a very complex task, particularly in young children, because the expression of autism is tremendously heterogeneous. Some children with autism have tremendous sensitivity around other people, and they are perturbed, sometimes even by proximity of others. Other children are actually very interested in interacting with other kids, but they lack basic knowledge of how to carry these kind of interactions in a successful manner. Some children with autism will never develop speech. Others are very talkative or verbose. Some children have tremendous learning difficulties, whereas others are very bright and talented in many different ways. So the expression of autism sort of varies along a number of dimensions, and we are still probably to identify other dimensions along which our children differ. What also complicates diagnostic differentiations early on is that it's a developmental disorder. What it means that the symptoms of autism are expressing differently depending on the child's age and cognitive level. So we can expect quite different set of symptoms in an 18-monther than in a 5-year-old, than in a 16-year-old, and in someone who's 25. So anytime we see a child for a differential diagnosis early on, we need to be very mindful. What can we expect from the child from the developmental standpoint? Of what kind of symptoms would be most diagnostic at the given age? What's important for our discussion today is that autism starts before the age of 3. And this is the developmental period where we'll be focusing on during this talk. So what are the core characteristics of autism in a young baby or in a toddler? Where I think the first thing that we all notice when we walk into the room and the child may have autism is that they are not really paying attention to things that otherwise are tremendously important to children without social disability. And these two things are faces and voices. And actually limited attention to faces and limited orienting to voice or one's name is sort of one of the first things that parents begin to notice when they begin to worry about autism. Another thing that's quite diagnostic and specific to autism is a limited drive to share experiences with others. If you ever interacted with a 12-monther or 14-monther, you know they cannot do a lot, but what can do is to pull you into their world of experiences by giving you something, pointing something, showing you something, for no other reasons, just for sheer pleasure of joining in the same kind of experience. This kind of set of behaviors is profoundly lacking in children with autism. Most or all our children, when we see them for differential diagnosis, have delays in language, and this is not specific to autism. A lot of children have delays in language, and they are sometimes consequential, sometimes not. What's very specific to autism is that our kids have major difficulties in communicating with other children non-verbally. They're not using their eyes, They are not using their facial expression and gestures to convey meaning to other people in the absence of speech. And that affects how they interact with the world, and in fact affects quite profoundly what they learn from the world as well. At this age, we are beginning to see emergence of speech, but speech, when it comes online, it's often stereotyped and not always fully functional. So children not always use the words they have to communicate in an adaptive way. The speech is often repetitive, involves naming, repetitive naming of objects around, or repeating verbatim question or phrases by other people. Already in the second year of life, we are beginning to see emergence of repetitive behaviors, restrictive behaviors, and unusual movements. They're not horribly necessarily pronounced, and sometimes it's difficult for someone who's not well trained in this population to detect them, but we're beginning to see seeking or avoiding of certain sensory stimuli, not protecting ears from the sounds, or seeking spinning objects. Instead of playing with toys, with a track, the child may turn it around and start flipping the wheels, or begin to show some unusual movement. It could be just subtle finger movements or toe walking. Again, not very pronounced, but present. So when does autism really emerge? When do we begin to see behavioral symptoms of autism that we can actually diagnose? This question has been on our minds for decades. And when I say our minds, I mean researchers in the field of autism. We asked this question in multiple ways, using a retrospective parental report, and more recently by following up babies who are at risk for developing autism. And it turns out that in the first year of life, it's really hard to see the kinds of symptoms that we would expect in a toddler. So we cannot sit with the baby, play with the baby, and see, for instance, poor eye contact or some gaze aversion, or these behaviors are really not coming online that early. By about 12 months, we are beginning to see delays in social communication, in use of gestures to communicate. There might be some withdrawal from enjoyment of social interactions. And parents see it and clinicians see it, so these behaviors are noticeable. The only thing is that they are not horribly diagnostic. The reason is that some children who have these difficulties at 12 months actually grow out of them. And some children who have autism are actually still okay around 12 months of age. So we are beginning to see emergence of the symptoms, but they are not yet diagnostic the way we define the symptoms or the way the things we are looking at. By 18 months, however, it's only 6 months later, we can reliably diagnose about 40 to 50% of children with autism. And that proportion increases dramatically afterwards. So what does autism might look like at 18 months? This is a time when we say, well, if the child seems to have symptoms, the child probably has autism. So in order to answer this question, we did something very interesting. We pulled data from across several sites in the US and in Canada, and we recruited infant siblings of children with autism. As you might have heard, due to genetic liability, these siblings are at enhanced risk of developing autism themselves. So with 700 children, we had a lot of power to actually ask a question: what are the unique combination of features that are predictive of later diagnosis of autism amongst younger siblings of children with autism? And we use a machine learning algorithm, something that we call, it's called classification and regression tree approach, in which we outputted ratings of the child's social and communicative behaviors, repetitive interests on 30 different items. We allowed for all possible combination of these features to be entered into the model, and then we asked the algorithm to select those features that are most predictive of later outcome. And we found something really interesting. If you look at this little tree, this is the little tree, it tells us which symptoms predict autism. And what we found is that there's a couple of groups here on your right, which are were put into this category because they have unusual eye contact, they don't share or engage others in their world or activities, and they also have very poor communicative gestures. And so there was a group of children with autism, and these are the prototypical symptoms that we would be looking for at 18 months if we were to look for autism: lack of eye contact, no sharing, and poor communicative gestures. So that was great. On the other side, however, we also have some kids with autism, but they were identified by a combination of different features. These kids had actually pretty good eye contact, and they were not that bad in a face-to-face interaction. What they were lacking, however, is this sort of behaviors that aim to engage other people in their activities, and they were showing some emergent repetitive behaviors. So why different features predict different subgroups of kids with autism? Well, when we looked actually at their verbal and nonverbal skills, here on the bottom, we found that the children who were showing this atypical combination of features were actually much higher functioning than those that were showing a very prototypical symptoms. What does it mean? This means that our current diagnostic criteria may be calibrated toward children with greater cognitive and language delays, and might be missing children who are higher functioning, especially at this very, very young age. Something to keep in mind as clinicians as we are interacting with children in diagnostic contexts. The implication of this study is that right now diagnostic tools and screening tools work on the assumption that one size fits all. What we are saying is that we might need to begin to calibrate, to increase the precision of a diagnostic evaluation. We might need to calibrate the screening and diagnostic procedures to specific subphenotypes within the spectrum. One of the most important things that we were concerned when we started diagnosing children at such early ages is what is the stability of the diagnosis at this age. And what we found, and this is research here at Yale, in England, other colleagues in the US that followed children for 1 year, 2 years, 5 years, 15 years, is that the stability of early diagnosis is quite high. 80 to 90% of children retain the diagnosis, and those who don't often have some residual difficulties or some other related problems. Predictors of later outcome when we see babies very early on are pretty straightforward. Less severe autism symptoms, higher cognitive skills which enable children to learn faster, and greater rate of progress over time. What also helps children in terms of overall outcome is not to have comorbid disorders, and I'm going to talk about this in 1 second. So I mentioned at some point a moment ago, I mentioned the special population of children within general population, which are younger siblings of children with autism. Prevalence of autism is about 1 in 68 children in general population. There are certain subgroups of our population where the prevalence of autism is much higher. And it's very important that as clinicians we are aware of that, because that might sort of put a radar on anytime we see a child with a specific syndrome or risk factors that they might be, that we need to monitor these children also for autism. So one of the groups that's at the greatest risk for developing autism are younger siblings of kids with autism. The reason is genetics. And as you might be aware, genetic factors are extremely powerful as etiologic factors in autism, with concordance rates for identical twins being around 80% or so. So for siblings who are not identical genetically, the concordance rates are somewhat lower. And depending on the estimates, they differ between 1 in 10 or 1 in 5. So 1 in 10 or 1 in 5 of younger siblings of children with autism are likely to develop the disorder themselves. Now this number is moderated by several other factors. One of the factors is how many children with autism there are already in the family. If there are 2 children with autism already in the family, the risk doubles. The risk for a younger child to develop autism goes up to 30–40%. Another very important factor is the sex or gender of the younger sibling. And you can actually see it here in this graph, where we have a comparison of recurrence rates amongst boys and girls as younger sibs. And you can see that boys are much more likely to develop autism than girls. And the risk factor goes up about twice. It's twice as high in boys than it is in girls. There's one more factor that's really fascinating, and there's a lot of work going on right now trying to explain this, is this gender, sex of the older sibling, all right? So if the older sibling, and these are the bars right here, if the older sibling is a girl versus a boy, then the likelihood of the next child having autism is much higher. And it has to do with, we think it has to do with the genetic load that girls need to carry in order to reach affectation status in autism. So this is all new emerging sort of science, and you probably will be hearing more about that. Important to think about it when speaking with the parents. Now the siblings, as you often hear, we are dealing with a spectrum, right? Autism spectrum, which means at one end of the spectrum we have autism, and the other end of the spectrum we have no autism, so to speak, but there's everything in between. So when you look at this figure here on the right, you can see that sort of metaphorically that if we think that there are children here who have autism, younger siblings who have autism, and then children who are developing typically, there is a group in the middle. And this is the group we call broader autism phenotype. These are the children who are at risk for developing some social difficulties, not necessarily meeting criteria for autism, and they are also at risk for developing other difficulties. Already when they are as young as 18 months or 24 months, we see that there's a significant proportion of younger siblings of children with autism who have language delays, social difficulties, emotional regulation difficulties, motor difficulties. And what's very important to keep in mind that when these children grow older, during school age and adolescence, these children are twice as likely to develop affective disorders, anxiety, ADHD, and a host of other difficulties. So again, the reason why I'm bringing it up is that we need to be very sensitive to clinical needs of younger siblings of children with autism who do not develop autism themselves. And if there are symptoms present, we should be actually acting on them, not worrying, is it autism, is not autism? It's irrelevant. If the child is facing difficulties because of their vulnerabilities, we need to intervene. It might, in fact, prevent some of the later mental health disorders that we see quite so frequently in this population. There are other groups that are also at increased risk for autism, and one of them are preemies. And as you can see here on the top, the risk for autism increases as the gestational age decreases, which is very high risk for autism in babies who are born with gestational age of 23 or 24 weeks. It's about 15% or so, whereas the average for the entire preemie group is 7% or so. There's a number of genetic syndromes where we see higher incidence of autism, including Angelman syndrome, Phelan-McDermid syndrome, and more recently, congenital heart disease. That group is still under investigation. We don't have a lot of really good studies evaluating prevalence of autism in this group, but current estimates sort of vary between maybe 3, maybe 5% or so. I'm sure we'll hear more about it in the near future. Sex differences in autism, right? Like many other neurodevelopmental disorders, boys are more likely to develop autism, right? If you read DSM-5, the ratio quoted there is 4:1, 4 boys, 1 girl. If you look at more recent studies that actually are based on populations that are not as, there may be less bias or more inclusive, the ratio actually goes a little higher, goes down, and the recent estimates suggest 3:1. It's a very interesting question. Why? right? Why more boys, why fewer girls? When we look at the severity of autism symptoms between boys and girls in terms of social difficulties, the severity is quite comparable between the groups. The girls, however, present themselves somewhat differently because they have typically fewer or not as intense repetitive behaviors, and also they tend to be more introverted, have more anxiety, have more depression, so they tend to be a little bit quieter. Boys, on the other hand, are very visible, a lot of stereotypies, and they're also very rambunctious, very active, and prone to externalizing disorders, including behavioral problems. So they are very, very, very visible. So in our field, again, this is one of these areas to watch in the coming years. So we've been asking the question, what produces this disparity between males and females? One set of answers have to do with how we diagnose the kids. Is the current diagnosis sort of a social construction, or is the disparity due to biological factors? These two hypotheses, or these two groups of hypotheses, are not mutually exclusive. They are probably both, most certainly both at play. So let me tell you about the first one. So why do we have fewer girls than boys? Very interesting. Several studies evaluated severity of autism symptoms in large population of children in England, in the States. And they found that boys and girls may have the same severity of autism symptoms, but boys are more likely to receive a diagnosis of autism in their community. Right? So there's some kind of a diagnostic bias that sort of prevents girls who are clearly socially vulnerable from receiving the diagnosis and being treated appropriately. And the idea is that perhaps the diagnostic criteria that we are operating within have been created based on how autism expresses in boys, not how it expresses in girls. So for that reason, it might just select those who fit that description, sort of it's a little circular sort of way of designing diagnostic criteria and using them. And this area, again, is under investigation. We'll hear more about it in the very near future. Another, the biological factors that have been sort of proposed to account for this disparity are heterogeneity. For instance, in terms of etiology, that there might be different factors, both genetic and environmental, that give rise to autism in males and females. The hypothesis that has been more strongly supported recently is a hypothesis which suggests that the ratio is due to the fact that the girls may have some kind of protective factors which are preventing them from expressing symptoms of autism unless they receive a major genetic hit. So in other words, they need to have more atypicalities in terms of genetics, genetic or epigenetic factors in order to reach affectation status. We don't know exactly what these protective factors might be. There are several hypotheses, one suggesting that there might be some genetic X-linked factors that are protecting the girls, or there might be some hormonal factors that also are sort of lessening some of the edges or around the social difficulties. Speaking of protective factors, we did a study not long ago where actually we described probably one of the first, or if not the first, sort of evidence for potential protective factor already in young babies. This is a study in which we use eye tracking technology to evaluate how babies allocate attention in response to a person who is sort of interacting with them, speaking to them, making eye contact. There are some toys. You can see the example of a screenshot from that video. So then at a given point, the child needs to make a decision where to move their eyes. And we conducted a study in 6, 9, and 12-month-old younger siblings of children with autism. And then we compare how high risk and low risk, these are the children without an older sibling with autism, perform on this task. In the red, you see girls, solid line, girls who are at high risk for autism. In black, you see boys, solid line, boys who are at risk for autism. And as you can see, something is really interesting. This red line is really, really high, both in terms of overall attention to the task or to the social scene, and also in terms of attention to the face of the speaker. It's a very interesting, intriguing, and puzzling finding. It might suggest that younger sister of children with autism very early on are employing perhaps compensatory strategies to try to get some more out of social interactions, try to maybe remedy some of the vulnerabilities they have. We are following up these studies, and we might have an answer what it actually is and what it does. But this is a first illustration of a potential protective factor already in infancy. So just to sum up our clinical implications of the discussions we just had, early diagnosis is stable. We have tools to diagnose children in a reliable way. We need to be very careful how we do it, because we need to consider multiple factors, not just symptoms of autism, but also the child's language, cognition, family factors, medical factors. But when we take it under consideration and the child's presentation is consistent with autism, that diagnosis is relatively stable. There's no reason to wait for anything. There's a reason to act and help families move toward toward implementing intervention services. Important to keep in mind that not all toddlers are going to be very prototypical. Right? The girls might look a little different. They might look better. They might be camouflaging some of their difficulties. Also, kids who are higher functioning might be not quite showing the prototypical symptoms that we expect at this age. Given the high risk that we know that number of populations or subgroups within our population has enhanced risk for autism, we have a mandate to actually monitor these children and screen them to make sure that we detect social difficulties as soon as possible. And in terms of predictors of outcome, we don't have tremendously specific measures, but just on a very general level, having better cognitive skills, verbal skills, and lesser severity, better progress or response to treatment within the first month typically bode well with later outcomes. All right, so we covered core symptoms of autism, and I wish this is where we could end. I wish this was all the problems children with autism and their families had. It's not true, unfortunately. The problem is that 70% of children with autism has at least one comorbid condition. And when I say comorbid condition, I mean a diagnosis of ADHD, affective disorder, anxiety, schizophrenia, many other disorders. Their prevalence is higher than in general population. So, and some children, or a lot of children, actually have more than one comorbid disorder occurring. What it tells us is that the factors that are driving psychopathology are overlapping to a large extent. But what happens is that when a child with autism has a comorbid disorder on top of it, it never bodes well for the long-term outcomes. These children struggle more. They have more difficulties in adaptation, social functioning. They are less likely to get more, they may have trouble getting an educational placement that's better matched with their overall skills. There's a high risk of hospitalization, suicidality, and many other problems. For many years, these kind of problems were overshadowed by autism, and we typically did not diagnose comorbid disorders in children with autism. It was like, oh, he has autism, so he's active. Oh, he's moody because he has autism. DSM-5 changed that, and right now a child with autism can carry co-occurring conditions as well. What's important is that for us as a clinician to also keep in mind that we are not horribly well equipped to differentiate or diagnose these disorders in kids with autism, because there's so much mushing around of various symptoms and their manifestations. There's a lot of really, really good work happening right now in our field to create better screening instruments for anxiety, for instance, or ADHD for children with autism, and also to create treatments that would be effective in children with autism as much as they are effective in general population. So again, something to think about, look for, the more information is coming. Why is it important when we talk about toddlers, right? Because we are focusing on kids under 3. We typically don't diagnose anxiety, ADHD, affective disorders in kids under 3. So why am I talking about it? Well, I am talking about it because we know from extensive research in general population that there are certain precursors or signs of upcoming difficulties, internalizing, externalizing problems already in infancy. And they are conceptualized under the umbrella of temperament, which is sort of a biological tendency to respond in certain ways with regard to positive affectivity, joy, or negative affectivity, such as fear and anger, and also ability to regulate emotions that arise in response to internal or external challenges. What's interesting that these patterns can be detected as early as 6 months, and they are relatively stable over time. And they might be sort of shaped a little bit by experience, but they are relatively stable over time. Extensive research in general population suggests that a typical positive and negative affectivity are related to later internalizing and externalizing problems. So for us, paying attention to how our toddlers are doing in terms of their regulation and emotional expressions in response to real world challenges it makes a lot of sense. And I'll tell you why right now. So we evaluated temperamental characteristics of toddlers with autism. This was probably one of the largest studies of temperament in young children with autism. The strengths of the study was not only its size, but we also compared children with autism with children with other developmental delays. I mean, it's not a big art to compare autism with typical kids. What we want to see how children with autism differ from children with developmental delays. And what we found was that children with autism seem to display less intensely positive emotion. They seem to experience less positive emotion in response to normative real-world environment. They also seem to be more negatively biased early on, and they have difficulties regulating emotions that arise when they're challenged by new things or things they don't necessarily like. What was very, very interesting is that at this age, severity of these emotional difficulties was not really associated with severity of autism, which suggests that there might be totally different domains of functioning that might arise maybe from different sources and then interact to produce complex phenotypes later on. We followed this group of children when they were 4, and there was very high stability. You can see these correlations here in the 50s and 60s. Very high stability within our group in terms of how, what were the temperamental vulnerabilities early on. What was also very important is that these early emotional vulnerabilities contributed later to severity of autism symptoms as measured 1 or 2 years later. So it's an interesting example how 2 different domains might interact and produce complex, reinforce each other and sort of produce complex phenotypes in the autism group. So just to sum up, we have there are very good reasons why we should be monitoring emotional development and emotional regulation in children with autism. It's not everything that you see is part of autism. It might be part of a different set of risk factors that are likely to produce symptoms later on that will make the lives of kids with autism less adaptive and lives of their families a little bit more complicated. because of the fact that the various comorbidities come online at different ages, right? We might start with some shyness early on, ADHD, anxiety, then we get into affective disorders and so forth and so forth. There is a need of monitoring kids with autism continuously for these problems. It's not screening them at 18 months and saying, ah, it's fine. No, because there are problems that will arise over time. So screening kids for these emotional difficulties throughout their early childhood and early school age is clinically indicated. And we hope that adequate or precise detection of these problems and intervention will help improve long-term outcomes in kids with autism. All right, we're going to switch gears now. I'm taking off my clinician hat and I'm putting on my researcher hat. Because we're going to talk about the developmental period that sort of spans between birth and about 12 months or so. And there are very few symptoms that we can call symptoms of autism during this time. So we are studying this time in development because we want to understand what's really happening. So is it true that autism really doesn't start until the second year of life? Or is it true that there are pathogenic factors which are already unfolding, but they are unfolding on a level that it's more difficult to capture with the naked eye? One of a line of research in my lab is focused on trying to understand why toddlers with autism have such limited attention, or ability to select for processing people's faces, especially when the people are speaking. It's a core symptom of autism. It's very important because we learn by directing our attention toward important sources of information. In other words, attention gates learning. If we are not paying attention to people and their faces, we not try to decode what they speak while attending to their facial features, we are missing a tremendous amount of information, which is going to affect not only how they develop language, but also how they develop social expertise. And Leo Kanner, this gentleman here, in 1943, he already noted that this kind of limited attention to people's faces and voices is present in autism very, very early on. And so what we did is we created an experimental paradigm which allowed us to replicate what we see in real world in the lab. And that replication is important because then we can take it apart. We can manipulate experimentally what children see, what do they hear, and try to understand what's generating this profound impairment in selective attention to social targets. And the study involved a video. I mentioned it before, but now I actually will give you some more details. In this video, this very wonderful young woman is speaking to the camera, trying to engage the viewer using eye contact, speech. Occasionally, she turns toward materials on the table, makes a sandwich. Occasionally, the toys start moving. So the child has to decide millisecond by millisecond where to direct their precious attentional resources and where the information is, what they're going to learn from this scene. When we take a group of typically developing children and show them this video, you can see that they're behaving in a very orchestrated way.
Hi again, sweetie. How are you doing? Are you having fun? You look so cute today.
So as you can see, all children kind of converge. When she's making a sandwich, they observe goal-oriented action. When she speaks, they monitor her face. When something happens perceptually salient, they look at her face. When we repeated the study with children who have autism, and you can see the graphs down in red, this is a group of children with autism, gray, developmental delay, and blue, these are typically developing children. You can see that children with autism are not completely lost. They are behaving quite well in many respects. However, there's one situation in which their behavior diverges from the other groups. This is the situation when she looks at the camera and speaks, trying to engage the viewer in a sort of using prototypical dyadic bits for engagement. In this situation, they look less at faces than children with comparable cognitive skills as well as typical controls. Since then, we replicated the study, other people replicated the study. We also extended the study, trying to understand what are the factors that are separating children with autism from typically or developmentally delayed children. And we found that the factors that are particularly important are the factors that have to do with presence of speech or combined presence of speech and eye contact. What we also did is we ask a related question. We know that sensitivity to faces and speech is present already in newborns. When we show a newborn a face-like stimulus or we play human speech, they are capable of orienting preferentially toward these stimuli. It's a very elementary orienting mechanism, subcortically mediated, something that gives a newborn sort of a leg up to know where to find the most important things that are going to be very relevant to their survival. So what we did is we asked the following question. We see these deficits in response to speech and eye contact at 18 months. Can we see them before behavioral symptoms come online? And we conducted a study in younger siblings of children with autism, and as we discussed, about 20% of them are likely to have autism. Another 30, 40 maybe, broader autism phenotype, and the remaining children will be developing typically. And we showed them the same kind of task as we did to children who already had autism. And as you can see, this blue bar is lower than even that of the children with broader autism phenotype, which suggests that already at 6 months, babies who are later become symptomatic of autism, they already are showing selective difficulty in attending to faces, especially faces that try to engage them in a face-to-face interaction. Since then, we replicated it with a different set of stimuli, and more recently, we actually replicated this phenomenon in the context of a face-to-face interaction. We took a very, very precise and very detailed measurement of the child's attention as the child was interacting with the person. And what we found was that was one condition in which children who later developed autism differed from those who didn't. And this was the condition when the person sat in front of the child and spoke. Not a condition when she sang or played peekaboo, it's only when she spoke. Which was quite remarkable because it really shows the correspondence of what we see in real world and what we see in the laboratory conditions. So what we do from here, right? We are beginning to see signals as early as 6 months in babies who later develop autism. These attentional difficulties are likely to be driven by a typical development of brain networks that are involved in prioritizing stimuli for processing, selecting certain visual or auditory inputs over others. These systems develop very early. They develop even as early as during pregnancy. So what we are doing now, we are actually extending downward our studies and focus on late prenatal and early postnatal development. What I mean by that is that we are looking for the roots of social and attentional difficulties that we see at 6 months already during the last trimester of pregnancy and shortly after birth. So how do we do that? We do that by conducting brain imaging studies. And what we are using is the resting state functional connectivity approach. This is a very non-invasive, non-demanding, and safe approach to learning about brain function and brain development. What happens is that in a brain resting state patterns arise spontaneously, so we can image a child who is asleep and still draw conclusions about how the brain is wired to process specific kinds of information. We can evaluate networks that are dedicated to processing visual or auditory information. We can evaluate how the networks that are involved in selection of stimuli for processing function very, very early on. The reason why this approach is likely to be effective, that we know that in older individuals with autism, some of the networks that I just mentioned are functioning atypically. So what do we know about current state of network development during the last trimester of pregnancy? It used to be that researchers thought that during the last 3 months of pregnancy, what we can see emerging in the developing brain are largely sensory networks. These are networks that are involved in processing visual stimuli, auditory stimuli, or, for instance, motor function. More recent studies suggest that even before the babies are born, there are certain foundations that are being laid for development of brain areas that are involved in emotion processing, in processing of speech, as well as social stimuli as faces. After the babies are born, in the neonatal brains, we are beginning to see the networks that are very important for us, such as saliency network, executive control network, or default mode networks, already form and emerge and become functional. And we also know that the properties of the networks are actually linked with later development. They are linked with language, cognition, and emotional development. So what we are targeting right now is something that may actually tell us something about the mechanisms that underlie early symptoms of autism. And we are tremendously excited about this work because this is truly a groundbreaking work, and we are sort of at the forefront of the new research we already started enrolling families. We have over 20 families already following, which is fantastic. If you hear of any family interested in participating in our studies, please spread the word. Everything that we do in our work, everything that we do in our clinics, everything that we do in our labs is really designed toward one purpose. And this is sort of my favorite video. And the purpose is to make sure that every child can live up to their potential at their best and bring as much joy as we can to their lives. Whoops. So I wanted to thank people without whom none of the work I talked about would be possible here at Yale. We have a clinical team. We are running a clinic for infants and toddlers who are at risk for developmental disorders or exhibiting symptoms of developmental disorders. It's the Yale Toddler Developmental Disabilities Clinic. And we also have a research lab called Social and Affective Neuroscience of Autism Program. Our group is very interdisciplinary, brings experts in multiple areas, and these are people who are the most amazing people to work with, and I'm truly honored to be able to do that for so many years here at Yale. So big shout out to the entire team. And thanks to the families who really make everything that we do possible. And our funders, who have to be mentioned as well. They're tremendously important, influential in our lives. So thank you so much for your attention, and I'll be happy to take some questions now.